Hello, my name is Dr. Jessie and I'm going to be presenting on the impact of COVID-19 on Australasian sonographers. The COVID-19 pandemic has had a vast and varied impact on the Australasian sonographic community. It has and is still impacting sonographers in unexpected ways in terms of reductions and increases in work hours and the impact this has, the necessity to diversify the type of work being conducted, and the necessity to rethink safety in the workplace, as well as job satisfaction and mental well-being. In order for the professional societies to best advocate for the sonographic community and inform future policy and guidelines, we wanted to be able to capture an evidence base of the true impact of COVID-19 on the Australasian sonographic community. In order to do this, we teamed up with the Australian Sonographers Association and some researchers at the University of South Australia to conduct a series of surveys over what we initially intended to be 12 months. The research team are myself, Brooke Osborne, Kate Lamb, and Sandy Morana. The first survey we did was designed to capture the initial impact of COVID-19 on Australasian sonographers. The pandemic was declared on the 11th of March 2020 and Survey 1 was released on the 8th of May and continued until the 21st of June. The first survey asked questions around demographics, changes in work hours, changes in work protocols, and types of scans being conducted, mental health and wellbeing and safety. Survey 2 was released on the 28th of September and closed on the 25th of October. This survey aimed to capture the initial 6-month time point. The second survey again asked questions around demographics, work changes, types of scan, mental health and wellbeing and safety. The questions were informed by the results of the first survey. We initially intended to release a final survey around March of 2021, but we realised that COVID had other plans for us and the pandemic was still well in swing in a time that we thought things would have returned to normal. This was also around the time that the Delta variant hit our shores. So instead of doing a final, now we're back to normal survey, we ended up doing another interim survey which captured the impact of the Delta time point. What we intend to do now is just wait until things return to a sense of normal, and then we will conduct our final survey. So what I'm going to present to you today are the major results and trends from the first survey, which was the initial impact. And that survey ran from the 8th of May to the 21st of June 2020. This survey asked participants to report their experiences since the 11th of March, the date COVID-19 was officially declared a pandemic. And this survey has captured sonographer experiences during what was, we hoped, the height of the pandemic, but we were then to see that Delta brought a second wave. So there were 444 sonographers who answered the first survey. A majority of the respondents were in the 45 to 54 year age group. 3% were 65 plus, around 2% were in the 18 to 24 year age group, with the remaining age groups representing around 20% of respondents each. Around 90% of the people who answered the survey were female and around 10% were male. In the sonographic population, because ultrasound is a postgraduate degree, we don't find that there are a large percentage of very young sonographers out there. The highest number of responses came from New South Wales, comprising 33% of our responses, with the Northern Territory having the lowest representation at less than 1% of participants. The graph above, however, shows the percentage of state distribution of the participants who completed our study compared to our association's data on the percentage state distribution of sonographers across Australia. So the ASAR, or the yellow bar there, is what percentage of sonographers across Australia are working in those places, and the blue is what percentage of sonographers from those places answered our survey. Obviously, this data didn't capture New Zealand, but you can see the distributions are fairly equal, aside from Queensland, where we didn't get as much representation as we had hoped for. Around 64% of our data came from sonographers working in capital cities, with around 30% from regional towns and the remainder from rural or remote areas. By far the largest percentage of participants were sonographers with greater than 15 years experience, accounting for almost half of the responses. Around 60% of sonographers who completed the survey worked in private practice, 20% in the public system and 20% a mixture of the two. To examine the data, we used Fisher's exact test to examine the relationships between the demographics and the survey questions. We set the level of significance at 0.05. There were some changes noted in sonographer work hours. The 68% of participants reported that their work hours had been decreased during COVID, while only 6% reported that their work hours had increased. In those who reported a decrease, the mean decrease in hours was 51%. In those who reported that their hours had increased, the mean increase was 37%. From this graph, we can see that the majority reduction was between 26 and 50% of work hours. Alarmingly, almost a quarter of those who reported that their work hours reduced reported that they had lost all of their hours. Interestingly though, 70% of people who reported that their hours had decreased or increased also reported that they had voluntarily chosen this change, with home responsibility or caring duties influencing the decision of 65% of these respondents. There was a statistically significant difference between state of those who did and did not choose their change in work hours. So the purple represents the percentage of sonographers in each state whose change was voluntary, and the orange represents the percentage whose change in hours was not voluntary. So you can see from this that the largest percentage of involuntary changes in work hours were seen in New Zealand and the ACT, where just under 50% of hours changes were involuntary. Sonographers in the Northern Territory, Tasmania and Western Australia were seen to have a much higher percentage of voluntary change. Another statistically significant difference was seen between sonographers working in the public and private systems. There was a much higher percentage of sonographers in the private practice that reported a change in their work hours, with a whopping 78% of those reporting that their work hours had decreased, compared to 22% working in the public system. There were also significant differences when we looked at what percentage of sonographers chose that change, with the percentage voluntary change being almost double in public sonographers compared to private. The survey contained a series of questions around personal protective equipment, or PPE. In regard to access to PPE, 80% of sonographers reported having access to gloves, 75% to masks, 51% to gowns, 41% to eye protection, and 6% to booties. However, this access was unconditional in only 36.5% of participants. Just under 4% of sonographers reported that they were somehow shielded from their patients. So if you have a look at this image of the screen, this is an example of the types of shields that some places put up to shield the sonographer from what here is a paediatric patient. Alarmingly, a quarter of participants who reported that they had access to protective gear reported that the protective gear was not appropriate for COVID-19 infection protocols. 40% of sonographers felt that they were not offered adequate personal protection at work. Access to protective equipment was seen to be even across the states, with the exception of booties and eye protection, where there were statistically significant differences in access. The graphs show that the percentage of sonographers in each state with access to eye protection and booties. New Zealand and the Northern Territory had the highest access to both eye protection and booties, with no respondents from WA and Tasmania reporting access to booties. It should be noted, however, that the participant numbers from the Northern Territory, WA and Tasmania were low, so these results should be viewed with caution as they may not be truly reflective. There were also statistically significant differences seen in PPE access between public and private sonographers. A higher percentage of access was reported by sonographers working in the public system across all types of protective equipment. What's interesting though, is that where it was available, sonographers in private practice had a higher percentage of unconditional access, with public participants' access being more conditional depending on the patient. The survey also asked questions around changes in scan numbers. 78% of participants reported that they had seen a decrease in the number of ultrasound scans being performed in their department. 30% reported that there was a uniform decrease across all different types of ultrasound scans. With respect to drops in individual scan types, musculoskeletal saw the biggest individual drop, with around 21% of people reporting a decrease in MSK scans or musculoskeletal scans, with the next largest drop being non-urgent scans, outpatient scans, and cardiac scans. Private practice saw the biggest decrease in musculoskeletal scans and non-urgent scans, but were more likely to report a uniform decrease, whereas public practice saw the biggest drop in obstetric scans. In those who reported that scan numbers had increased rather than decreased, the biggest increase was seen in obstetrics. Not surprisingly, given the previous statistic, the largest increase in obstetrics was seen in private practice, and this suggested that these types of scans were being moved from public to private. Comment was made on this within the survey, suggesting that this was to make way for the COVID-19 emergency patients. Public practice saw the biggest increase in COVID lung scans, emergency scans, and cardiac scans. Interestingly, there was a corresponding drop in emergency scans and cardiac scans in private practice, suggesting that these types of scans were being moved the other way, from private to public. The survey asked a series of open-ended questions on department protocol changes. Various changes to protocols were reported that can be organised into 4 broad groups: reducing the immediate exposure for staff and patients, scan-related changes to reduce imaging time, changes to imaging protocols, and changes to the timing and performance of scans. Major trends seen in reducing the immediate risk of exposure were a reduction of the number of people allowed in a scanning room. That includes support people and student sonographers, the requirement to clean and disinfect the room and the probes between patients. However, there were some complaints that no extra time was being allocated for this. Only having the probe on the machine that was being used at the time, with the rest of the probes stored externally. No paper forms in the department, so everything was being done electronically. Sonographers filling out the paperwork rather than patients being given the forms to fill out. All scans being performed with the patient rolled away from the sonographer in order for them to reduce the risk of breathing on each other. Patients no longer being asked to hold their breath in order to reduce the risk of them blowing back in the sonographer's face, or asking patients only to breathe through their nose. In the same vein, some patients were asked not to talk during the examination. No coughing manoeuvres being performed for hernia studies, and scans on suspected COVID patients being delayed until they returned a negative COVID test. And finally, patients suspected of having COVID being scanned on a portable machine in their room rather than coming to the imaging department. Then there were themes around scan-related changes in order to reduce the amount of time spent with the patient, and these included limiting labelling or no annotation on the ultrasound images, all measurements being performed after the study and the patient had left the room, limiting image optimisation, and this is making your image look aesthetically pleasing, only obtaining essential pictures, taking cine loops rather than still images, limiting physical assessment of patients prior to the scan, and patient contact time being set at a maximum of 15 minutes. Some changes to imaging protocols were reported, and these included no transabdominal scans being performed for pelvic ultrasounds, and all pelvic ultrasounds going straight to transvaginal scans to reduce the amount of time with the patient. Studies being targeted to just the clinical question being asked rather than the normal department protocol, and 3rd trimester scans being only for biometry and no repeat of the anatomy assessment. And finally, no 3D or 4D imaging being performed. The largest group was the changes to timing and performing of scans. Within this theme, sonographers reported vascular scans being ceased due to the amount of time with the patient, and that patient being sent to computed tomography or CT instead. A 12-month follow-up scans being delayed. Monitoring scans being delayed. So these are routine follow-up scans where people monitor a previously detected pathology. Only urgent scans being performed. Pediatric hip scans being scanned every 10 weeks instead of every 6 weeks. Infant hip ultrasounds being performed at 8 weeks of age instead of 6 weeks of age, with a follow-up scan at a further 8 weeks. Third trimester follow-up scans being done at 28 and 34 weeks only, instead of 28, 32 and 36 weeks of gestation. And increased thresholds for performing routine transthoracic echo and transesophageal echo and stress echo. Any scan whose outcome wouldn't change the management of the patient was not performed. Dating scans with no concerning features not being performed or deferred until 12 weeks. All referrals being required to have proper clinical information and blood test results attached before ultrasound assessment. And transthoracic and stress echoes being limited to essential or urgent as per the ASE CSANZ guidelines. There were some issues raised due to the changes that were made in departments, and these included increased pressure on sonographers due to all the cleaning that needed to be done. So some participants reported being allocated extra time to clean while some were not. There were comments around reduced ergonomics, and this was due to the increased number of bedside or portable ultrasounds that were being performed. But also due to scanning patients further away, so there was a bit more distance, and this requires sonographers to extend their arms out further than normal, causing shoulder and ergonomic problems. In some cases, sonographers were required to make longer obstetric videos because a partner was not allowed in the room, and this extended their scan times. In terms of sonographers' feelings around the scan changes, most sonographers felt that they were not being rushed to complete patients and COVID was not impacting how well they did their jobs. However, there was a statistically significant difference seen between the states, with Victoria and Queensland showing a higher degree of COVID impacting how well they did their jobs, and a swing towards the other direction of no impact in Western Australia, Tasmania and the Northern Territory. Interestingly, private sonographers felt slightly more impacted than public sonographers. There was also a statistically significant difference between the states in regards to whether people felt that were interacting less with their patients, with almost half of sonographers in SA and Victoria feeling their patient interaction had reduced. Finally, the survey asked questions around sonographer wellbeing. Overall, sonographers felt supported by their employers. 50% often, 30% sometimes, and only 18% reported never or rarely feeling supported by their employer. There were statistically significant differences seen between the age groups, with the older age groups feeling more supported by their employers than the younger age groups. Public sonographers felt significantly more supported than private sonographers, and likewise, public sonographers felt they had a more supportive leader. In regards to whether people felt informed about what was going on, differences were seen between public and private sonographers, with public sonographers feeling more informed than private sonographers, with just under 15% more public sonographers reporting that they often or always felt informed. In regards to whether people felt their scanning position was at risk, again, the only statistically significant difference was seen in public versus private sonographers, with public sonographers feeling less like their scanning position was at risk. Almost 1/4 of private sonographers felt that their scanning position was often or always at risk, compared to 13.9% of public sonographers. In regards to whether people considered seeking a different source of income, overall, almost all sonographers reported that they sometimes considered an alternative source of income, 37% never, and 21% often or always. Again, the only significant relationship to the demographics was that of public and private. The graph above shows the overall numbers in purple and then split into public and private, with public being blue and private being green. Sonographers in public practice were more likely to never or rarely consider a different source of income, while sonographers in private practice were more likely to often or always consider a different source of income. Ideally, it would have been lovely to have a pre-COVID baseline for these statistics, but will be interesting to track and compare these responses over the coming surveys. In regards to pride in their work, 80% of sonographers often or always felt a sense of pride in their work, while a quarter reported that this sense of pride had increased during COVID. 14%, however, felt their sense of pride had decreased during COVID. There were significant differences seen between age groups, with the trend showing increase in age corresponded to an increased sense of pride, with the lower age groups more likely to feel less of a sense of pride in their work. There were no significant differences in sense of pride between public and private sonographers. However, public sonographers were more likely to report that their sense of pride had increased during COVID, and private sonographers were more likely to report their sense of pride had decreased during COVID. Sonographers felt like they were working on the front line. 38% of participants felt they were often or always working on the front line, with only 8.5% reporting that they never felt like they were working on the front line. Perhaps not surprisingly, public sonographers were twice as likely to feel that they were working on the front line than those working in private practices. So how are we coping? 40% of sonographers reported feeling more isolated than normal. However, general well-being around connectedness with friends and families were good. There was, however, significant differences between states, showing that those in Victoria and the ACT felt the most isolated, whereas those in the Northern Territory felt the least isolated. It will again be interesting to monitor these statistics over the prior surveys. Thank you so much for your time today, and I hope you enjoyed this talk.